Looking at the statistics from our own San Francisco Health Department, we're in crises. As an African American population, we are in crises in this city. And nowhere on the budget do I see it reflected. When you look at a budget, you know where someone's priorities are. And we knew when it was AIDS, we definitely knew that that was a priority. Well, for us, African Americans, it is not that. Epidemiologists have said this is your problem, this is where the issues are, and still in all, I don't see anything. So I want to really thank this council, because I think you all have stepped up.
The Health Equity Council has been in formation for a little more than a year. And basically what we are focusing on are policy recommendations, policies in the city. Health policies that we can look at from a grassroots perspective and bring and recommend to our supervisor, and she can do what she wills with them. But that's the relationship that we want to have. So over this past year, we went around to the 4 traditionally black or minority neighborhoods: the Western Addition, Baby Hunters Point, OMI, Viz Valley, Sunnydale, held community forums and asked folks, first of all, what do you think the government and health institutions should be doing in order to improve conditions around, and asking for policy recommendations, and also asking the community, what should we be doing ourselves around these issues? And we've got a wealth of information that we've been pulling together. Finally, it was in May, it all came together in a number of policy health recommendations cutting across three key areas. And what I want Joe Harris to do is to sort of give us an overview.
As Perry mentioned, here's just a quick flash of what the council is in terms of how we define ourselves, and again, it's around changing health policies, improve the health of African Americans, and to reduce health disparities. So that's all pretty straightforward. These are the statistics that I'm pretty sure you've seen a lot of.
Yes.
Sorry for the small printer, but we had to get everybody in. And this just summarizes, what are the leading sources of disease and death in the communities that we're talking about. And you'll see some amazing things. You were just talking about violence, and it's amazing that it's #1 in Hunters Point, but it's #10 in the Western Addition.
I was just looking at that.
Yeah, I mean, you could spend a whole day studying this chart and talking about it. And as I understand, the health department is about to update this, because this is about 3 or 4 years old or so. But it's the latest data. In fact, it's the same data that was presented at our May conference.
But one thing I would add too is interesting as we take this to neighborhood, to see the neighborhoods talking about the differences
exactly.
between this,
yeah,
and the things that they wanted to focus on in their neighborhood versus another.
Right, exactly.
Excuse me again. The source of this data, is this from the health department? Okay.
Yeah, exactly. Yeah. So we've been waiting for the update of this as well. But Perry is right. As we went to community to community, we actually would take this chart and highlight it in red so they could see their particular statistics. And again, we focus on. We got a lot of positive comments there. Just to summarize, once we looked at all that, and as Perry mentioned, we broke into these 3 areas, which emerged really out of our work, our research, and talking to people to sort of get a snapshot. We said it was mental health, physical health, and environmental health. And again, here are all the related diseases, which I'm pretty sure most of y'all are familiar with. But this began to anchor our thinking in terms of an overall snapshot of where we're going. Now, here's where we kind of brought it all together. And as we were talking on the way in, we said it's a shame that there isn't a single rifle shot that you can hit to resolve health disparities. But the answer is simply you cannot. And as we worked through the year, and we were broken into these different teams, we tried to hone it down to just one thing. And it became clear to us that actually they're all related. That you can have someone that has a traumatic stress event that then has heart-related disease as a result of that, or not be able to take their medicine as well. Or you could have toxic exposure like particulates that then leads to heart disease, right? So it became clear to us it would have been really unfair for us to try to say that there was a single shot bullet solution, but this was systemic, right? So that made our job a little bit harder, but it made it, for us, it made it true to the facts and true to the experience that people were having. So as we worked through, we said, well, let's get clear on what our goals are and what the benefits are if we take this kind of systemic, holistic approach. So the goals, again, are clearly to reduce the health disparities, to support community-based actions and prevention. We'll talk about that in detail as we work through. Again, support the adoption of policies, and then open the door for health-related careers and jobs in the community. Benefits, reduced healthcare costs, particularly around lower emergency room visits, improved treatment adherence, things of that nature, to provide better health care, support preventive activity, and then, of course, healthier, productive citizens who can then participate more actively in the economy itself. So these are sort of the high-level pictures of what we had in mind as we worked through. Now, in fact, as you were talking, Tony, you said, well, we have this system in San Francisco, and here's our view of kind of how we want to think about that system is, of course, we have the private hospitals, the public hospitals, the big players in healthy San Francisco, but the core of what we're recommending is that qualifying, culturally sensitive, community-based health services agencies also be a major link to what we're talking about. And we're sitting here with a classic example of BCOA, and also what these other organizations in this room are talking about. They're telling you they have ideas, they have solutions, there's a role that they can play. And as you said at the beginning, Tony, we can't do this alone, and there's an evolutionary approach that's needed. So we're kind of grounding what we're saying.
Sure. And let me highlight an example of where this truly has worked. At BCOA, thanks to the Health Disparities Project, we are doing critical mass health conductors that I talked about before. So what is happening now with some of the public health clinics in our area, folks that are coming in with diabetes issues, etc., they're being treated there. But we receive a fax from the clinic saying we would like this person to enroll in this community health program. And then they come to us and they go through the program. It is a good partnership. And it's a pilot that we're doing in District 10, but it's the right kind of fit. And we believe we can do more of this with more of our community-based organizations and hospitals.
Great. So what is it that we're really talking about here? When we go back to our three key areas, the core of what we're saying is that if we have identified physical health, mental health, and environmental health as the key sort of anchors for an overall holistic approach, we should begin to think about organizations in these areas, community-based organizations in these areas, that then form that sort of systemic approach. So, organizations like Health Conductors on the physical health, right, or BCOA, right, or maybe some of the mental health clinics, or organizations like HERP, which is here in the room, Mary's organization in terms of environmental issues. So the whole idea is that over time, we would use this kind of approach to be very, very specific about where we were focusing and targeting dollars and the build out of community-based organizations.